Things that gain, which we are very, and always have been, very aware of, is that you can do the best guideline in the world and it can gather dust because nobody's interested in implementing it. And it's just as important as a methodological quality of guidelines is to ensure that they're implemented and used and not stuck on a shelf somewhere. And we know that there's loads and loads of research now, properly done empirical research on the implementation of guidelines. And that's why each year we try to get someone along from NICE who's interested in that end of things, the actual implementation. And this year we've got Chris Connell, who is the implementation consultant at NICE for the Midlands. He supports, oh dear, it's an awfully sad list this. He supports Stoke City, which is a difficulty in itself. His one wish for if anything could happen in the next couple of years would be that there would be more care outside of hospitals and moving into the community. That's his one wish for the health and social services. And that's a considered wish, because before he moved to NICE, he was general manager at Worcestershire Acute Hospital, which has a huge A&E department, and he was aware of the kind of the targets, particularly A&E targets that he had to implement day and daily. He moved then to NICE, and as I say, now he's the implementation consultant for the whole of the Midlands. So we're very pleased indeed, Chris, that you've come along to talk to us.
Thanks, Ryan. Right, good morning, but it's not pretty. But if you ever see a Rory Dewlap throw on YouTube, it is quite astonishing to see. So we are what we are. Anyway, moving on. So my job is implementation consultant for NICE. What that perhaps really means is that I reflect NICE's increasing interest in finding out what's happening to its guidance at local level, encouraging implementation, trying to raise awareness, and really importantly, getting feedback for what people want, what people think about what we're doing. To try to feed that back to NICE at Manchester and London, so aiming for that virtuous cycle where what we do is and remains relevant to what people do in health and social care. What I'd like to talk about today, developments at NICE and the implications for local organisations. Some of what I'm going to talk about is driven in part by health policy in England, but nevertheless, I think most of the issues are germane, they're relevant to any local organisation, whether you're in England, Northern Ireland or elsewhere in the UK. So these are the 5 areas I'd like to touch on. NICE quality standards, NICE support for QIP. I'll explain a little bit more about what that is if people aren't familiar. Just a brief summary of practical support for working with NICE guidance. I was fortunate enough to be invited here last year and I touched on that then, but I'll signpost people to that. NHS evidence. I don't know how aware people are of NHS evidence. There's a couple of nods. The next steps for NHS evidence, and I'd be interested either now or during the day to get any feedback on what people think about NHS evidence. And with some caveats, further support from NICE to local organisations. Obviously it's slightly different here to the West Midlands where I work. And we're going to run out of power in a moment by the looks of it. So, yeah, thank you.
Something has come up with this.
There we go.
There you go.
That's great, thank you. I'm going to try and speak for about 25 minutes and give 5 minutes for questions, and I'll take questions afterwards or through the day. If I do mention things that people aren't familiar with or it's new to you, do please raise your hand and I'll do my best to explain. Before quality standards, I thought this might be worth mentioning. If I'd been here last year, I think I was here last year, I'd probably put a slide up saying these 4 or 5 pieces of NICE guidance and put a screenshot of what they are. I think now it's really time to kind of draw people's attention to that it's more than the guidance. NICE is more than the guidance. If you look at these four blocks, it's worth taking note. Look at the top there, advice on new and existing treatments. NICE for 10, 11 years has provided guidance on new drugs, new technologies. That is starting to change. We've been commissioned to produce new streams of guidance on medical technology and also for diagnostics as well, although the latter, as we've yet to publish guidance on that. We've published the first guidance on medical technology. On the right-hand side, clinical guidelines, nothing new to NICE. The QOF UK-wide is beginning to take shape. But for the first time, NICE has been asked to produce standards. That's something that's new to NICE, quality standards, and I'll touch on those in a moment. Health promotion to disease prevention since 2007, NICE has had a role in producing guidance for public health. And increasingly, that's hopefully spoken to audiences beyond the NHS, in local government, and also the voluntary sector. But certainly within England, the legislation currently before Parliament envisages NICE taking a role in producing guidance for social care. That might be something that might be of particular interest to you here. Subject to that bill being passed, that will take place from 2012. An evidence, comprehensive evidence service, NICE assumed responsibility for the National Library for Health in April 2009, and that's become NHS Evidence. And that's an area that in tight economic times has consumed a significant amount of resource within NICE as we seek to deliver a service, make evidence more accessible to people. And it's really picking up the point that Robin made earlier of implementation. One of the key issues of implementation is accessibility, and I'll touch on that now. If you look here, the types of guidance that NICE produces is growing. And I think we've been quite fond of NICE sometimes, certainly I have, of kind of describing what a technology appraisal is, a clinical guideline, cancer service guidance, public health guidance, medical technologies guidance, diagnostic guidance, it goes on. And that's great. We believe the product, what we produce, is relevant. We believe it's good quality, high quality. The other aspect to it is the guidance got to be accessible, and increasingly it's got to be flexible in how it's used. And at the moment, there are different guidance formats where NICE has begun to try to answer that. The NICE guideline, which I'm sure most people here will be familiar with, the quick reference guide, the QRGs, where increasingly we've tried to colour code who should do what, which organisation should do what. Guidance for patients and carers, trying to explain to people what evidence-based care they might expect to receive from health and social care. More recently, we've produced a NICE web format where we've started to move away from people having to kind of clunk their way through a PDF format, if you like, on a search, looking for things that might be of interest or relevant to them. And then there's the full guideline, which is a really necessary document because it contains all the evidence, all the search strategies, the whole building block on which the guidance is built. It's pretty big if anybody's looked at any of those, if you want to read them. So in terms of trying to make things more accessible, this is where we are at the moment, and that's fine up to a point. But from May, we are trying to take things a step or two further forward, and we launched something called NICE Pathways. The feedback that we got from people is that it's great that you've got a technology appraisal on this, and it's great you've done an interventional procedure, a clinical guideline. But what have you got to say about epilepsy? What have you got to say about diabetes in a way that we can access? So we're starting on NHS Evidence. These will be placed on NHS Evidence, is bundling together all related NICE guidance, including the quality standards, relevant implementation tools. And it probably won't look quite like this. This is a mock-up, but it will give you a feel. And what we're really looking to do is move away from searching through a PDF. If I'm planning a health service, I might be interested in the whole of the pathway on epilepsy. If I'm a clinician, I might be particularly interested in children, adults, whatever it might be. And what we're seeking to do here is give people the opportunity to either drill down quickly in areas that of particular clinical concern, areas that might have service implications, might have cost implications, might have cost savings that people might need to know about. And also just to begin to link that through to the implementation tools, the audit support, for example, the costing tools, those kinds of things. So we're hopeful that this will be the next stage in making guidance more accessible, more user-friendly for people such as yourselves. And really this is just a kind of another way of looking at that kind of those 4 blocks that I put on earlier. The Red C is, at the top, is probably of relevance and interest. If current legislation goes through Parliament, NICE will change its name and will become the National Institute for Care and Health Excellence. And that reflects, although the acronym will stay the same, that reflects 2 things. One, NICE will be moving out of the NHS, partly because its role with local government will increase, and it was felt that NICE could better speak to local government from outside the NHS. And also because NICE will be re-established under primary legislation rather than as a special health authority within the NHS, which we hope and believe will secure our independence still further. Quality standards. This relates to liberating the NHS, obviously an English policy document. I won't go through the blurb, but I'd draw your attention to this to say that the quality standards are a strategic driver within the NHS. But I think they, in England, but I think they do have relevance to local organisations wherever they may be. You'll see there, if you do read, when you get the copy of the slides, the comprehensive library is the words there that NICE has worked hard to get into these documents. And we are working hard to try to rapidly expand the work programme, straining every sinew really. What we really want to do is create that comprehensive library of standards for all the main pathways of care, and then extend that into social care as well. So what does that mean? I guess this is what, as good a definition as anywhere. There's a couple of words in there that are really important. Obviously high quality, cost effective resources, making resources count is obviously really, really important. But they're also going to be specific and concise. And if anybody's looked at the first 5 that have been published, certainly by comparison to a clinical guideline, they're very thin documents. They're very short. They're not published other than on the web. And what we really are trying to identify across a pathway of care are what are the key markers of high quality, cost-effective care. So what are the 10 things that might give you an indication that the stroke service that you provide is of high quality, demonstrates good use of resources, and is something that patients and their families can have confidence in. As with everything from NICE, they're based on evidence and they're produced collaboratively. There's a whole process that goes behind them. If anybody's familiar with the clinical guidelines process and the other guidance producing processes, you'll see the roots of that in these. And to give you a little bit more of an example, this witch's hat, if you like, tries to demonstrate where the standard fits in. There's audit, evidence of variation in care, there's the key policy documents, National Strategy on Dementia, the NICE clinical guideline on dementia, and it's from that that the clinical standards are drawn. Those 10, those 12, the kidney one came out last week, it's actually got 15, but those key markers of high quality care are drawn from the guidance. So if you are a clinician, if you are looking to audit, that doesn't obviate the need to use the clinical guideline. But if you are a planner, you're a commissioner, whatever you might be, a general manager, you might, or you will want to use these standards to get a feel for what is the quality of care that we produce at the moment, what are the priorities for development, what can we afford, what are we going to aim at, and what will the time span be. The topics are coming to us thick and fast. Only did this slide a couple of weeks ago. It's already slightly out of date because the chronic kidney one came out last week. There's about 30 there on the right-hand side, which I'm not sure you can read terribly easily at the moment, but you'll get that. You'll get that in the. I'll leave you a copy of this presentation, so you'll have this for reference. So already we're looking to cover a lot of the major disease pathways. We would anticipate completing these by 2014.